Good morning, everyone, again. We're going to get started formally here. My name is Andrew Saxon. I'm an addiction psychiatrist here in Seattle, working at the VA and the University of Washington, and I'm very pleased to welcome you all here to our today's meeting on effective approaches to addressing patients with substance use disorders in the emergency department. I believe that I am one of the course co-chairs, and I believe the reason that I was asked to be one of the co-chairs is because one of the sponsors, National Institute on Drug Abuse, is an organization that I've been working with for several years, and they happen to know that I was here in Seattle, and that they can often ask me to take on tasks, so I agreed to it. But I think what they didn't perhaps realize, although it's displayed very proudly at the forefront of my CV, is that before going into psychiatry, I worked as an emergency room physician for 4 years in a very rural area out on the coast of Washington State. And so in some ways, I'm the perfect person for this job. And when I was working down there, it was a pretty primitive area. There were still trees around, and the main economic driver was logging. And I can tell you that there probably are still many people walking around with pretty ugly scars from the chainsaw lacerations that I was the only one around to repair because we couldn't always get a surgeon. So, but when I was doing that work, I probably did exactly all the wrong things with the patients who came in who were probably substance using patients. When patients would come in complaining of pain and specifically requesting opioids, I was always too worried about the person in the next cubicle who just come in from an MVA, or the person in the next cubicle with a COPD exacerbation, and it was just so easy for me to give the person a prescription for opioids and send them on their way. What I didn't realize until later is that in that small town I began to develop a reputation, and so I got more and more of those people. And fortunately, these days we know a lot more about those problems. We have very good interventions that we can, which we'll be discussing today, that we can put into effect right in the ER, and we have really good treatments that we can refer people to. So we have come a long way, and that will be the topic for discussion today. I hope, in addition to that, I hope that all of you who might be from out of town have an opportunity to enjoy being in the Seattle area. If you can steal a few moments from the conference or stay an extra day. The weather forecast is uncharacteristically sunny, so appreciate that. And think about definitely at least going down to the Pike Place Market, where you can see the very first Starbucks that ever existed. And if the weather is clear, maybe go to the Space Needle, where you'll get a really good view. And I was also going to recommend that if you have an extra day and the weather's good, go out to our 14,400-foot volcano, Mount Rainier. But with the government shutdown, I'm not going to recommend that you go to a national park. And of course, the government shutdown has unfortunately deprived us of some of our important speakers today, which is why you have a revised agenda, and we'll do our utmost to make up for that. And I guess the advantage is that that may give us a little extra time, so we don't have to be we don't have to restrict some of the speakers to their absolute time limits. Although I just got back from, and one of my new responsibilities because of the shutdown is to moderate the morning session. I just came back from a conference in France yesterday, and one of the things that I realized that was culturally different is when someone goes over time for their talk, no one stops them. And if someone gets up to ask a question, they spend 5 minutes making a speech before they ask their question. Just culturally, maybe better, it's very spontaneous, but that's graded on me. So I will make sure that people will have extra time, but I will make sure that we're on time with our schedule. And with that, I'm going to introduce our other conference co-chair, Megan Ranney, who will also welcome you. But we're thrilled to have you all here.
Thanks, Andy. Thanks, Andy. So my name is Megan Ranney. I know many of you, but for those that don't, I'm a practicing emergency physician and researcher at Rhode Island Hospital, which is a level 1 trauma center in Rhode Island. We treat about 120,000 patients a year, and we're the primary teaching hospital for Alpert Medical School at Brown University. For those of you who don't know, Rhode Island has the dubious distinction of having one of the highest rates of substance abuse, drunk driving, and opioid overdose in the country. So this topic is quite near and dear to my heart, and I'm really thrilled to see so many people here today to discuss ways that we can disseminate the solutions that we have and ways that we can create answers to the questions that we don't know the answers to yet. I know that we've all been struggling on a daily basis in our emergency departments, not only to address the issue of opioid misuse, but also the struggles of our patients with substance addiction. As we know, substance use costs the U.S. over $500 billion a year, and it's estimated that if you screened all of our emergency department patients, as many as 20% would meet diagnostic criteria for substance abuse. We know that patients with a history of substance abuse have higher rates of recidivism, more comorbidities, and higher chances of poor outcomes. They're also among the most taxing patients for us as providers to treat. So I'd argue that we have both a moral obligation and, with the new healthcare rules coming into place, a financial incentive to take better care of these patients. As our esteemed panel of lecturers is going to discuss, we do have solutions to these problems, many of which were developed by the people who are speaking today. However, new issues continue to arise, particularly with the recent epidemic of opioid misuse. And we as a specialty continue to struggle to disseminate the tools that we do have, which is I think why most of us are here today, because we're interested in taking these tools and putting them into practice in real life. I'm really honored that ASAP, CDC, and NIDA recognize the importance of this issue and the degree to which we are trying to change things in our emergency departments and sponsored this session today. This would not have happened without the support of all three organizations. It's such a neat opportunity to be here with the thought leaders, the primary researchers, the people who have put this stuff into practice in their own emergency departments, to learn from them and to, again, hopefully take stuff home to our own EDs to start to disseminate. Unluckily, as Andy said, because of the shutdown, many of the folks from CDC and NIDA are unable to join us today, but we'll fill them in after the fact. Because the NIDA people aren't here, I am therefore going to give the acknowledgments from NIDA, so bear with me for a second. But the National Institute on Drug Abuse, Substance Abuse, and the Mental Health Services Administration's SAMSHA blending initiative would like to officially thank their colleagues at the American College of Emergency Physicians for their hospitality and support. The collaboration between the blending initiative and ASAP has been instrumental in making this meeting a success. I'd also like to thank our colleagues at the Center for Disease Control and Prevention for their participation and their time in the development of the workshop content, and SAMHSA for its support in promoting the meeting to its local constituents. I'd also like to acknowledge and thank the meeting faculty, the planning committee, the staff at Synergy Enterprises, Katya, Joanna, Sean, and the rest, the Addiction Technology Transfer Center Network, and the National Drug Abuse Treatment Clinical Trials Network, all of whom really did put in countless hours to make this meeting a success. And finally, a special thanks to all of you. This meeting is going to be a success in large part because of your participation. We are going to have a lot of interactive parts to it, so you'll have a chance to get your real-life questions answered in addition to kind of listening to the lecture. I hope that we're going to come away from this meeting, like I said, with some solutions that we can take home and with some really nice next steps. And I want to thank you all for traveling here today and taking the time to join us. In light of the shutdown, we do have a couple of small changes to our program. The biggest one is lunch. Linda DeGudis, sadly, can't be here because she's a federally funded employee. So instead of having Linda and Jeremy, who also can't make it because of the shutdown, instead of having Linda and Jeremy talk, we're actually going to be doing roundtable discussions, which I think in some ways is going to be even more useful for us. At lunch, what we're going to do is each table is going to be given one or two of the ASAP clinical guidelines on opioid use to discuss. You're going to discuss the evidence. We're going to discuss kind of how to implement them, how to kind of recognize the guidelines in our own hospitals. And then we're going to come back and have a moderated discussion, and Knox Todd and Lewis Nelson have kindly agreed to moderate that discussion. We'll be scribing that as well, and we'll hopefully have the results of those discussions turned into a publication that we can send to all of you and also disseminate more widely. The only other big change is that unluckily Raul and Len can't be here, so Andy and I will be moderating the panels, but hopefully that won't take too much away from the panel's experience. With that said, that's kind of all the admin stuff. Bathrooms are out and around the corner to the right. There's also water fountains over there if you guys need water. Lunch is going to be served here. We're going to have about a 30-minute break to get lunch before the roundtable panels start. And the only other thing is if you're going to ask questions, please use the microphones because stuff is being recorded. So we do ask that you use mics instead of just standing up at your seat. So with that said, I do want to move on to the full day program. Thank you again for coming. I'm excited to see all of you, many old friends here and also some new faces who I look forward to meeting. And I'm going to turn it back over to Andy and we'll start with our first series of lectures. Thank you.